Great. All right, so let's go ahead and let's go over this. Let's go over this and see if everybody's kind of on the same page with it. All right. So let's see how you did. Define cardiology. You said this is the study of the heart. The right side of the heart sends blood to the lungs, and it's called the pulmonary circuit. The left side of the heart sends blood to the body or the system, and it's called the systemic circuit, right? Okay. The vessels that bring blood to the heart are called veins, and the vessels that carry blood away from the heart are called arteries. And y'all are visualizing this, right? And the chambers that actually receive blood to the heart, where blood is coming to the heart by way of veins, those chambers are called atria. And the chambers where blood that are going to eject blood away from the heart are called ventricles. All right, then this is basic, so you have to kind of know this, thinking of this as we go forward. So great. If you didn't know it before, it's okay, but that's the kind of thing you got to get now. Okay.
What was that called?
What was what called?
What exits the chambers?
The chambers where blood exits from the chambers known as ventricles. Ventricles. Okay, so what's the function of heart valves? That's exactly the function of heart valves, or valves period, is to prevent backflow. Because when blood is moving, it needs to keep moving in the direction it's supposed to be moving, right? Not backwards. Which again should also make very kind of good sense to you, right? Because if blood were moving backwards, it would put a strain on those tissues and the pump, but these pumps not working. All right. Okay. What's the explain what's making the heart sounds, the lub and the dub, and what you put, Julie?
The lub is the closure of the AV circuit or valve, and the dub is the closure of the simulator.
So that's actually specifically exactly right. I'm going to accept if you just put those sounds of being, I'm going to accept on here that if you put that those sounds are being created by the closing, the slamming shut of the valves. For the test, you need to know that. You need to know that the first sound is the closing of those AV valves. There's AV, when blood moves from the atria into the ventricles and the valves shut, so that when the ventricles contract, blood doesn't go back up into the atria, does it? They'll go into the arteries. Blood will go into the arteries. Fair enough? And then when blood has been ejected into the arteries, the second sound is going to be the slamming shut of those semilunar valves, so that when the blood goes into the arteries, it won't back up into the heart. So the first sound is the slamming shut of the AV valves, and the second sound is the slamming shut of the semilunar valves. We said we hear it as one sound because there's really two pumps working in what? Synchrony. All right, so we go with that. Just can't stress that enough.
So
yes, sure.
Number 7, anything to do with opening and closing.
Opening has nothing to do with it, so that would be wrong. That's not a sound. You don't hear something open, but do you hear it shut? Yes, you hear it shut. So define edema.
Excess fluid in the tissue
spaces. It's an excess of fluid in tissue spaces. Sometimes we can actually see it, and it looks like swelling of those tissues, doesn't it? Can we always see edema? No, because sometimes it's pleural edema. And what is that going to be putting pressure on? So sometimes pericardial edema. And what's that putting pressure on? The heart. Sometimes it's cerebral edema. And what's that putting pressure on?
The brain.
Brain. Right. But edema is an excess of fluid in the tissue spaces, putting pressure on those tissues, isn't it? Putting pressure on those tissues. All right, so good. I'm really thank you guys for being here. The bonus question was what exactly does A and F stand for? Okay, some things is not exactly.
Something I can't pronounce.
Something is not it. So anyway, okay, so it's atrial, okay. And then what's its function? I'll get partial bonus points here. What's its function?
Lower
What is
blood pressure.
lower blood pressure. You know how it does it?
Yes.
All you have to do is put lower blood pressure, but do you know how it does it? How?
Hormone to the kidneys to tell it to let go of sodium.
Yes, let go of sodium. So it's going to cause sodium levels to go down, but because it's letting go of sodium and water follows sodium, right? So you're losing blood volume, and therefore blood pressure is going down. Okay, good. All right, so good.
You said expels sodium.
So it causes the kidneys to lose or excrete sodium. Yeah. You know, I swear, guys, I do give partial credit. Most of y'all know I do. Don't leave blanks because I will always give some credit if I can think of like what they might have been thinking, right?
Mm-hmm.
So expel, excrete, lose, you know, those are all good words for that, right? All right. Good. Ready to continue on today? Hope you feel like you know more about blood and the heart than maybe you did know, and circulation is going to be important to do. When we think about the heart and the position of the heart, we do understand that the heart is said to be mediastinum, kind of, which is kind of the middle of the sternal region, but it's slightly to the left, isn't it? Usually on most people, isn't it? Slightly sitting off to the left. And if we notice this heart is supposedly not a whole lot bigger than your fist, the size of your heart. If we look at this heart, we see now why it's shaped the way it is and why we don't even expect the right side to be the same as the left side, do we? And so we understand that. We understand there's really two pumps here. Looking at the external anatomy of the heart in this illustration, let's see if I've got even a better picture of it. Not really, but okay. Yeah, I will in a minute. There's these little, they're look like little blue puppy ears. Sometimes that's what they look like. And they're actually called auricles because what's an auricle? An ear. So I call them puppy ears because it's almost what it looks like when you're looking at a heart. They look like two little flaps on the top of the heart. They're the atria. That's where the atria are. Sort of blurred that. But anyway, so we're looking at this external anatomy. We know it's sitting kind of to the left. If we looked at the lungs in this thoracic cavity that we're seeing, we see that the lungs are compartmentalized here with these sacs, and there's fluid between the pleural sac and the lining of the lung. And this one is too. But then we look at the heart, and the heart looks like it's in a sac as well, doesn't it? With fluid kind of around it. So I want y'all to pay attention to that for a second. If you look that it's sitting slightly to the left lung doesn't even look like the right lung, does it? The right lung has three distinct lobes, doesn't it? Where the left lung has only what? Two. And it looks like there's this cutout here where the heart sits kind of perfectly. This cutout in his lungs, you don't need to know it right now, but you will when you get to the respiratory system. This is called the cardiac notch of the left lung. Because this notch is where the what is sitting? The heart. Okay, so I want you to think about this heart and the position of the heart here and where it's sitting. And then I want you to realize if we looked at this heart and we did a coronal section, which you all know what that means because of your lab. It's a front, we removed the front part. So we're looking in here at these chambers. This is the left atrium and the left ventricle. And we took a little slice of this and we blew this up. What we would actually see is that the heart is sitting in this tough sac. And that tough sac that y'all are going to see in the lab today from one of the hearts is still in its pericardial. It's called the pericardial sac. And it's a really tough, fibrous kind of sac that is isolating and really compartmentalizing the heart in this structure. Have you ever heard of pericarditis? guess what does itis as a suffix always mean?
Inflammation.
So guess what's inflamed?
Around the
Pericardium.
heart.
The sac is inflamed. That pericardial sac is inflamed. Do y'all know what one of the signs and symptoms of inflammation is? Swelling. Fluid will come to the site. So now if more fluid is at the site, can the lung fill the way it's supposed to? When blood is being brought to can the heart fill the way that it's supposed to if there's fluid pushing on? No. If the heart chambers, this is the upper chamber, the atrium, fill and contract, fill and contract, fill and contract, keep filling and contracting, fill and contracting. And it's got to be able to do that, but it's the fluid that's bathing it. Is all of a sudden doing this? Are you filling and contracting the way you were? Okay, that's what happens in pericarditis. It's a serious diagnosis, isn't it? And what it means is that sac that the heart is sitting in is inflamed, and more fluid will be there than should be there. Now, there's supposed to be some fluid there. In this sac that the heart is sitting in, there's going to be a fluid interface in here with the heart. Now, why do you think, thank you, keep doing this. This is just the left atrium. Now, we know the right one's doing it too, at the same thing. And it's supposed to have room enough to fill and contract, to fill and contract. And we said it's sitting in a sac. Why do you want some fluid? And it's called pericardial fluid. Why do you want fluid in this area? Why do you want it? So it doesn't rub, and there's not going to be like friction here interfering with it. So it has to be just the right amount of fluid. But if there's too much fluid, it's impeding that filling, isn't it? Thank you. All right. So y'all can picture that, can't you? Now, today, y'all are going to look at hearts, and you can see that the heart, the outer lining of a heart, is the whole heart's hand. And you're going to see that it looks kind of slick. This is called the epicardium. I know they call it visceral pericardium, but no one in the world is going to call it that for you. They're going to call it epicardium. This is the lining on the outside of the heart, the outside, not the sac, but the actual outside of the heart is the epicardium. And guess what we can see people having? Epicarditis. Okay? And now y'all will know where that inflammation is. If we've cut the heart and we are looking at these chambers, this is the left ventricle, this is the left atrium, and they're surrounded by muscle because it's the muscle that's contracting, that's ejecting what? Blood. This is called the myocardium. And this thick muscle layer today, y'all are going to see, it's significant. It's the most significant part of the heart. The heart is a muscle. It is. And what kind of special muscle did we say that is from our histology study? Skeletal muscle attaches to bone so we can move, right? Two different bones, so that when Ned contracts, we move. But what was that special tissue muscle type that we find in the heart? Cardiac muscle. That's what it's called, cardiac muscle. And it actually has a different histology, than skeletal, and we'll talk a little bit about it. But the heart is mostly this tissue. Y'all will see that today when you look at cut sections of the hearts. You're going to say, yeah, we're looking inside the heart. This is muscle, right? And that's the myocardium. Guess what you can also have inflammation of?
The myocardium.
And we call that what? Myocarditis. That's exactly right. Myocarditis. Does that sound like that would be a good diagnosis either? Mm-hmm. No. And then we're going to look at those chambers today. We're going to have hearts that are dissected. Y'all can dissect a couple if you want. You're going to have these hearts that are dissected, and you're going to see this slick-looking lining just on gross anatomy, which you can see with your eye. You'll see it's a slick-looking lining inside of those chambers where blood is coming in and filling. Then when the myocardium contracts, it sends it to the next chamber, and then when this contracts, it sends it out of the heart, right? But you're going to see the chambers themselves have kind of a slick-looking lining, just like the outer epicardium is. This is called the endocardium. And the endocardium can also get infected, and that's called endocarditis. right? So we understand that. What causes all these itises of the heart? What is the most common cause of all these itises of the heart, do you think? Well, it's a type of infection. What kind of infection do you think? What class of infections? Do you think it's viral? Do you think it's fungal? Do you think it's bacterial? What do you think it is? Bacterial. Okay, it's circulating. It's usually viral. It's usually viral, which is the good news. It's usually viral. Now, that's kind of the good news because usually the damage is less and it's less mortality rate associated with viral any of these. But it doesn't mean they're completely safe and you can lose function of the heart after having any of these. So when somebody has had these, they really need to always follow up and see how the heart's functioning. Because when you've had any of these, you can actually have forevermore some loss of heart function, right? Now, bacterial ones of these, you're in the hospital, you're on IV antibiotics, you're in a serious shape. Doesn't mean that they're 100% fatal, they're not. But it's way more serious than the viral ones. Is everybody good with that? So viruses, bacteria, it's rare that you'll have a fungal cause of it, and usually that's in the lab. All right, so everybody good with that? So the heart, the beauty of the anatomy and evolution of this organ, along with the pleural, along with the lungs, is that they are so compartmentalized. They have so many layers that are isolating them and separating them. Is this protected? Yes. And this is why you don't always hear about pericarditis or endocarditis or epicarditis, is because they really are protected, right? Anyway, so now we'll know the structures. Do you think you'll have to label those structures when we get the heart anatomy lab? You will have to label those structures. And I just explained them to you, so I hope they'll be kind of easy for you. When we're looking at a coronal section of a heart, meaning the front has been taken, you've done a dissection where you remove the front, so you're seeing inside. I told you this is so, or I think I told you guys, this is so kind of misleading, this illustration, because it's flat. And is the heart flat? No. So I need you all holding these hearts, turning them, even if it's the plastic ones, turning them upside down, sideways, in any way you can get them, so that you kind of get that this is just an illustration and it's a flat illustration, which isn't giving you the full picture of what these really look like. But we know these two upper chambers are the what? And we know these two lower chambers are the what? And we know that these flappy looking things are the what? That's exactly right. And we know the ones between the atria and the ventricles are? And we know the ones between the ventricles and the arteries are? Y'all are so awesome. That's so awesome. Now that's great. They actually have specific names. So I'm going to want you to know those too when you label them. All right, when you're labeling the heart, you will need to know that the right atrium and the left atrium are going to have a valve known as the tricuspid. This one is called the tricuspid. The right AV valve is the tricuspid. The left AV, I want you all to write, now you know it's between the left atrium and the left ventricle. LA, left A, I want you to write lamb, like Baba, lamb, like sheep lamb. LAMB. And the reason I want you to write that is so that you will remember that this particular valve is sometimes called the left AV, but it's sometimes called the mitral valve. And on some reports, it's going to be listed as the bicuspid valve. So are all those things the same valve? So write down lamb for now, but make sure you know what those letters stand for. They stand for the left AV, mitral, and bicuspid. Yes, you have a question, Alexis?
Just a little tip. When I took this class before, someone said try before you buy. So the tricuspid
Well, and when you say before, you're just saying like when if you were looking at it right to left, the right side, unless okay. So any of those little things that can help you, that's awesome. Thank you for that. Yes. What was the right called? Tricuspid. Tricuspid. I'll show you in a second why they named that, but you don't really need to know why. It's because the tri has 3 cusps. And if we did a different kind of dissection, we'd see those 3 cusps. It takes a different dissection. You have to do an oblique dissection. But if you did an oblique dissection through this, you'd see that it has 3 cusps. And guess how many this one has? 2. And that's what, it's also known sometimes it's a bicuspid. All right. And especially why I want you to know these valves is because when something goes wrong with these valves, and I want y'all to think about why you would say this. Could you intuitively maybe guess or think about which one, the tri or the bi, because which one might have the most problems?
The one, right?
And why do you think?
Because it's sending out the blood. Wait, now I keep switching.
The blood for the body.
We can send out the blood to the body.
Because it's sending out the blood to the body, I want you all to see, you noticed even from this illustration, the muscle mass on this side is much less than the muscle mass on this side. And we said that makes good sense, because this muscle, when it contracts, only has to send blood to the where? How far away? To the lungs. But on the left side, this muscle is way more intense because it's sending blood to the system. So as this ventricle contracts, sending blood through the aortic valve, the semilunar aortic valve to the aorta to the system, you understand when it contracts, what's it putting pressure against? This bicuspid valve, this mitral valve. And if y'all have ever heard of valve problems in the heart, and we said we know that the sound that a faulty valve makes is called what? A murmur is the sound that a faulty valve makes. Maybe y'all have already heard of mitral valve prolapse. Have you? And it's because, and it makes kind of good sense, because this valve is getting a tremendous amount of pressure put on it as it slams shut. And if it prolapses, that's where you're going to hear that murmur, right? All right. So we've done a lot of the anatomy, haven't we? What is the sac called that the heart's in? Pericardial sac. What is that fluid called that's between the sac and the heart? Pericardial fluid. Okay. And what is the outer lining of the heart called? Epicardium. What is the muscle layer called? And what is the chamber layer called? Lining called? And you know the valves now, right?
Can you go back over the valves?
Okay, so this is the tricuspid. The right AV is the tricuspid. The right semilunar is the pulmonary valve, because it's sending blood to the where? Pulmonary arteries that send blood to the lungs. So this right semilunar is called the pulmonary valve. Now let's go to the left pump. The left pump, we've got the left atrium here, and between the left atrium and the left ventricle, we've got the what valve? It's the left AV, so it's sometimes called the what? And sometimes known as the? Are you gonna have to know both those names? Yes. Mitral valve or bicuspid. Now, when this left ventricle contracts, it sends blood to the aorta, which is an artery, isn't it? That's going to end up carrying blood to the whole system. But this valve between the left ventricle and the aorta is a semilunar valve, and it's called the aortic valve. Can you really see it really well on this picture? No, because it's really kind of behind, it's we can't see it because it's kind of behind. But are y'all going to be looking for it on your specimens today, the models?
Mm-hmm.
Yes, so that you could label this. All right. Did I answer the question that was asked? All right. So in the external anatomy of the heart, I want you all to get this idea of this external anatomy of the heart. The heart itself is an organ. I think sometimes people forget this because I've had a lot of students who have a hard time getting their head around it. The heart is sending blood to the system so that what can happen? So oxygen and nutrients and all the good stuff can be exchanged to the tissue, and the waste products can be put back in, and sent back around, and the heart's pumping to the kidneys and the liver, and it's flame, it's being filtered, and it's going to the lungs. So it's needing to do all of that. Is that right? So it's really true. Because the liver and the kidneys and the central nervous system and everything needs oxygen, needs nutrients, needs waste to be picked up. But doesn't the heart too? Doesn't the epicardium and the myocardium and the endocardium, don't they need blood supply too? How does the heart get blood supply?
It has its own system. I don't know.
Okay.
I mean, it kind of does. Yeah.
It's got to have a constant blood supply. Let me, if anything, it's more important that these tissues get blood supply than anything else. Because if this pump stops working, guess what's over?
Everything.
Everything's over. Because it's the pump, the two pumps, right? So all these tissues have to have blood supply. The way the heart is getting blood supply, see, they can't draw everything here, but the way the heart's getting blood supply are through arteries, coronary arteries that are actually feeding this tissue blood. These coronary arteries are keeping the heart oxygenated. The heart cardiac muscle almost exclusively depends on aerobic respiration, which means that there had better not be a time when oxygen is not flowing to that heart. These coronary arteries, you all are not, and they're labeled somewhere on here, but you're not going to have to label them. This is the back side of the heart. You're seeing some coronary arteries down here too. And we'll talk about them again in a minute, but you're not going to have to label them. But do you understand that coronary arteries, front and back, they're nourishing the heart? And there has to be a constant supply. They cannot be blocked, these arteries, these coronary arteries. As they are delivering blood to the heart tissue and blood is moving through those arteries, it goes to vessels known as arterioles all the way to capillaries. And then the blood's being returned by coronary veins. Coronary veins, it's being returned to the right side of the heart so that it can then be sent from the right pump to the where? The lungs to pick up what? Oxygen. And then it can come back to the left side to be pumped to the system again. Do you get that? When you've heard of somebody having bypass surgeries, triple bypass, quadruple bypass, are they cracking the sternum and going in there and doing that? No. No, they're not. They're going through arteries. They're going through axillary arteries. Sometimes athletes still go through the femoral. But they're going through an artery, feeding cameras, feeding what they need in there. And they're going to those coronary arteries. And they're feeding them in. And when they see a coronary artery blocked, they're either going to put a stent in that artery to open it, or they can actually even balloon it, or they can do a bypass sometimes, but they're going in that way. They're not cracking sternums. If y'all ever known anybody who had coronary bypass, they didn't have a cracked sternum. You know what's really cool, and it's just happened like in the last couple of weeks, to replace valves, they used to have cracked sternums and go in open heart surgery, right? But they've successfully gotten a technique now where they don't have to do that. And the recovery time is so much easier, and they say it's just as good as this procedure. So I'm so excited about that for people who have to have valve replacements now, not having to go through all of that.
So that's when they crack it up and they replace the valves.
Yeah, and sometimes they crack crack you open because they want to do like, I mean, it's emergency, and they're doing, massaging hearts. But no, when they're doing bypass, they're not cracking your stomach.
Did they ever used to, like, way back to do that?
Like in the
Not
80s.
in a typical thing, no. No, they've been going through femoral, they used to always go through the femoral arteries and feed through. They'll do it in an emergency situation, or they'll do it when there's something crazy going on, but they don't do that unless it's an absolute, unusual situation. So, and you've heard of triple bypass. That means there were 3 arteries, coronary arteries, that were blocked. And you'll hear about people, and they'll say that there was 90% blockage of so-and-so artery, coronary artery, right? You good, Maya and Ray? Y'all are good?
Yeah.
All right. So I want you to think about blood having to go through those arteries, and now think about 90% of that artery being blocked. How much blood was really getting to that heart muscle? Hardly any. You wonder how would they make that, right? So anyway, that's what that means. So what vessels nourish the heart? Coronary arteries. Then as the blood's delivered to the heart, where oxygen and nutrients and whatever and waste picked up, it's returned back to the right pump by way of coronary what?
So how many coronary arteries do we like have?
Quite a few. And are any 2 people exactly the same? I'm going to get to this where you're going to see the major ones in just a second. But I want to get to this, so you're going to spell a word. There's something called anastomosis. And, oh God, okay, you want me to get to it now. I know you want me to get to it now, don't you?
You said it.
I know. All right, so anyway, guys, well, look. Okay, here it is. All right, so this is talking about the major ones, okay, the major arteries. Anterior means what? What? It means the front. Interventricular. Where do you think that's going to? Yes, so in these walls between the septum of the walls of the ventricles, right? Circumflex artery, you can see sort of where this one is. By the way, no 2 hearts are exactly alike. None. No 2. This is why thoracic surgeons have the biggest egos of any people you've ever met. They have like God-like complexes. And I'm glad they do, because you don't want somebody doing a procedure, even if they might have a chance of having to crack the sternum, that doesn't have confidence. Do you know what I mean? Yeah. So it's okay, but they have that reputation, those surgeons, and they are proud of it. So anyway, because no 2 are exactly alike, and they know what it should kind of look like, but they don't know exactly what it's going to look like. And here's what I want you to realize, that what's really, this is the word, I changed the type so y'all would get it. If someone is developing a blockage to these coronaries over a long period of time, because of aging, higher cholesterol levels, smoking, we know what causes the blockage of these. We know the things that can cause blockage. If it's happening over a slow period of time, this is kind of a beautiful thing, because our bodies will acclimate. And anastomosis is a term that's used not just for the heart, but it happens in the heart, where the body will eventually reroute blood through other vessels to get to that tissue, if it's happening over a slow period of time. This is why you will have older patients who you will be bringing in as paramedics and whatever, and they've had like a dozen heart attacks in the past, and they might be having another one now, and they're still talking to you because their bodies have rerouted things. And then when they eventually pass and you would ever look at their hearts, you'd be able to see that was a heart attack, that was a heart attack on the heart. You're looking at it, you can tell where they had like half a dozen heart attacks. Because the body has that ability, except it doesn't if the blood supply is cut off suddenly. So this is why, who are you the most concerned about age-wise having a heart attack? A very old person or a young person? A young person. Because if a young person's having a heart attack, let me tell you something, it's a sudden blockage. The heart can't take it. The body can't adjust. and it's going to cause the death of that heart muscle past that point, and then they're young and have a good immune system. So the immune response is going to end up bringing more fluid to the site, more cells to the site, and blow their heart wall out. So I'm not telling you to ignore the old person that has chest pain and only treat the young one, but I'm telling you, don't ignore that young person in your ER that has chest pain. Rule out, what's the first thing you're ruling out? Heart attack. Rule that out first, no matter what. No matter what you might think, rule out a heart attack first, right? If there's any chest pain involved, because they're the ones who are going to die on you quicker, right? And it's because of the anatomy. We know the body does this. And this is also why you got that grandfather, grandmother, whoever you got, that you here had a triple bypass and 3 of the major arteries were 90% blocked, and they're still with you. It was because of what? Anastomosis. Right, that it happened, and that's a good thing. That's like a wonderful thing, and that can happen. And if any of y'all have known anybody who had bypass surgery, those patients that had bypass surgery, double, triple, quadruple, they feel better immediately when they wake up, don't they? Why? Because
It's not blocking.
they're finally, they will tell you, and they just had this kind of major procedure done, and they're under whatever, and they'll say, no. They feel better because the pump's working better, oxygen's getting around better, and they feel better immediately. It is just like why you see people who have lung bypass surgery, where y'all ever see, you get to see a lung heart bypass surgery, you thinking, dang, wow. But those people, I think about cystic fibrosis, because they're the ones I've seen, they haven't been able to take a breath ever. A good breath. They don't even know what it's like to be able to breathe, what we take for granted. And they'll wake up from double lung, sometimes they'll be hard to surgery just because it's an easier procedure. They'll do it, and as soon as they wake up, they'll have a smile on their face, and I've actually heard one of them say, "This is what it's like to breathe."
I've had 2 pulled off my lungs. Oh my God, that was like the best feeling ever.
Because you were able to breathe. We take things for granted until we lose them,
I
right?
was like, do that this time, do that.
Well, the other side might not have needed it. You don't want to listen, you don't want to just be put in unless you really need it. Okay. But good. So you guys know that. Let me go back in case I forgot something. But are y'all going to know the heart valves, the names of the heart valves, the 4? You are. This is that section, Kristen, I was telling, if you did an oblique dissection here, like right here, and looked at an inferior view of that, you would see these valves kind of in a different way, and you can see why the bicuspid is called that and why the tricuspid is called that. But, you don't really have to.
Is that the same view that we're supposed to see the symbol part of that?
No.
Oh, okay.
No. That's like totally
That's
different.
weird.
That's totally different. Okay, and you know what's really, sorry.
No, it's okay. What's the most, like, you can do a bypass for? Like, I heard of, like, quadruple bypass, but is there anything, has there ever been anything more than that?
I have not heard.
Because I know that there has been.
Yeah, I haven't heard of more than that. So, no, I haven't heard of more than that. Does anybody else do
More than like a
more than quadruple bypass? All right. So I don't have you all label the chordae tendineae or the papillary muscles, but maybe it kind of makes, I don't have you all label that, so you're not having to, but maybe it makes sense to you that these valves have to be attached to something, right? These valves that are opening and closing have to be attached. So these tendons, if you will, chordae tendineae, are attached to these papillary muscles. And so they're getting signals about the relaxing opening, and then they're slamming shut. There's signals that are going. And so that's all that is, but I don't have you all label that, okay? But that is a cool picture of it. When you do, this is a crazy picture, but when you do a, and I want to do this and then we'll take a quick little break.
Look at the quiz.
And it's going to be what I call a gimme quiz, because it should be just perfect. made sense to you, and I can go over it. Guinea quizzes are ones that I think that you all need to get 100s on. So anyway, because I give you exactly what it's going to be. It's not like you don't know what questions will be asked. I'm going to tell you. I forgot what I was going to say before I got to this, though. Echo cardiac. Y'all have heard of echo cardiac. So when you're looking at echo, you're actually able to really see how that blood's coming in and flowing out, and how these valves are opening and closing. It's really kind of cool. Has anybody had an echo? Yeah. Do you want to share? You don't have to.
I can. I was an ECMO baby when I was a newborn, so
And that was years ago when people weren't expected to survive that.
I think I was about number 50 in the country. And so they had to reroute my heart and lungs to do the work for me. And so they had to cut the artery in my right neck. And so I don't have that artery anymore because when they finished, they cut it off.
And rewrite it blood. What was the heart thing though that what were they correcting?
It was persistent fetal circulation.
So what was happening was your blood was coming into that right side, and instead of being routed to your lungs, it was going straight to the left. I think is that what so it wasn't becoming oxygenated. And there are a lot of different things in babies that can happen with fetal circulation. Sometimes babies have, and we call it like really, it's almost like the wrong wiring, but these vessels are reversed. Mm-hmm. And so they'll have to go in and fix those. But I do want you to, because everybody understands maybe that as blood is coming to that right side, this right pump is separate from the left pump, because the right pump is sending blood to the lungs to pick up oxygen, get rid of CO2, come back to the left side to be sent to the system. Everybody good with that? All right, but in a fetus, that's not what's happening. Because are the lungs oxygenating blood in a fetus? No. The lungs in a fetus, the little alveoli, are closed. So where are fetuses getting blood oxygen from? Oxygen to their blood from? From the mom, across the placenta. Now the blood, listen to this carefully, the blood of the mother and the fetus should never mix. Never. Because that fetus is foreign to the mother. But at this interface and the placenta and umbilical cord, there is going to be nutrients crossing across the tissues to the fetal blood. One of those nutrients is oxygen from the mother's blood. So the oxygenation of the fetus, the blood circulating in the fetus, think of this as a fetus, this heart. This blood, oxygenated blood, is coming to the right side, and there's a hole here, and it goes directly to the left side, to the left atrium, and then the left ventricle sends it to the fetus's system. So does that make sense to you guys? So what it means is, because remember, even though it doesn't look like this right atrium and left atrium are close, they are. They're kissing. They share a wall, a very thin wall. And in a fetal circulation, there's a hole here called the fossa ovalis. There's a hole, and it's supposed to be there because oxygenated blood is coming straight across here, and that's the way the circulation is in a fetus. But as soon as that fetus is delivered, what's going to happen? The little alveoli have to open. And now this right pump should be pumping to the lungs. And the little hole that's between the right and the left atria, the hole has to do what? Close. If it doesn't close enough, quickly enough, then the fetus is, the neonate now, not a fetus, now born, neonate is going to suffer. Because some will be being sent to the lungs, but some will be still moving through that hole, and it's kind of wasted energy for that heart. So if the fetus exerts at all, are they suffering? Are they becoming oxygen depleted? They are. So even crying can cause cyanosis. What is cyanosis? Fluid, which is, or darkening, purpling. And you're realizing that the fetus is not getting good oxygen perfusion. And it's probably because of that hole that's between the right and left is still too big. We're all born with a hole in our heart between that because we needed it for what? Fetal circulation. But it needs to start closing down quickly. So pediatric thoracic surgeons, if there's a baby whose fossa ovalis doesn't look like it's doing what it's supposed to be doing, and if it's serious enough, they won't even let the neonate go home. They're going to do that surgery before they go home. But some are so kind of mild, the holes aren't so big, that the fetus does okay. The fetus has energy to eat. The fetus has energy to cry. The fetus is doing okay. Not the fetus, the neonate is doing okay. So they'll watch it, and they'll sometimes watch it up to 2 years of age. And if it hasn't closed by then, they usually have to go in and close it.
How soon do they actually want it to close? Like, what's the time?
It depends on the pediatric surgeon. It really does. It just depends because different ones will have different things that they say.
Okay.
As if there's, and again, different neonates are going to have different presentations. Some neonates you're going to realize, no, this is going to require surgery pretty quickly. We need to get them in there and close that off.
Okay, so
Because they're getting so much still being sent through the left that they're not able to really even cry, have any energy. They don't have good perfusion of oxygen to their tissues. So that's an emergency situation. But there's all different degrees of that, all the way up to some neonates that don't even get picked up while they're in the hospital that they had. But what will happen is they'll come back for well baby visits, and the parent will say something like, you know, when they cry for any length of time, their lips start changing color, or it looks like their fingers and And is it normal for appendages on neonates to turn dark? Is that normal? That can be kind of normal. So then, it just depends on how severe it is. And it depends on the pediatric surgeon, wherever you are. Some of them are much more lenient and letting it go longer.
So, can I be like a person or a neonate that's like a little purplish in color? Like I remember, like my dad said that when he was born, he was like
a blue baby.
Yeah.
Well,
But they didn't do.
they're called blue babies.
He just said he was very plum color. That's
Yeah,
what my
plum
grandma said.
color.
Yeah, like a purple.
Purple. So yeah, but that's a little bit normal. That's a little bit normal.
So it doesn't
Y'all have heard of
necessarily-
APGAR scores, right? And what you really want to see is a neonate not looking dusky or looking too cyanotic. You want to see how well they perfuse. But there's an easy way to see that too, and that's by doing oxygen sats, so you can just look to see. And it's normal. We're all born with a hole in heart, but it will close.
So do you know if that was what Lisa?
Yes.
Okay.
Yeah.
So we were all sick babies with heart issues.
You did. You were. We're special. Okay, so now let's get to the crazy picture real quick, and then you take a break. Now look, I think in one of the editions of your book has it wrong. There's typo. This is why you should always question what you read, right? What's that saying? You only believe half of what you see and not think of what you hear or something. What's that saying? I don't know. That's kind of true. So anyway, so if you ever have a doubt about this, question it and look up other places, but I'm going to tell you the correct thing. All right, so look, what this is representing is this idea that, well, I'll use this. Okay, it's this idea that if you are a red blood cell, how long did you say? If you're a red blood cell and you've been pushed out into peripheral blood and you are delivering oxygen to tissues, picking up CO2 and bringing it back to the lungs so that you can breathe out CO2 every time you exhale, you're breathing out CO2 from end products of aerobic respiration. You don't get that. So anyway, you're a red blood cell, that's your job. How long do you live in the system? Peripheral blood? About 120 days. You're doing that through the system. Is that right? All right, so that's your job as a red blood cell. So I want you to think of yourself right now as a red blood cell. And I want you to think of yourself as a red blood cell that has delivered oxygen to the toes. See these little toes? That's a little, I don't know how many toes I have. Anyway, that's toe. So you've delivered oxygen, right? You've delivered, you've dropped off O2, delivered it, you've picked up CO2, and now you're a red blood cell and you're coming back to the right side of the heart, right? If you were at the toes, you're coming back by way of the inferior. Why would we call that inferior? Because it's below the heart. I can't tell you, I'm going to have 2 or 3 of you just because I know what happens. Y'all will label this one the superior and this one the inferior. Does that make any sense? But I will have 2 or 3 of you do it. Don't you be the one. Okay, just don't. Because that means that you're just really stressed and you're stressed and you're memorizing and you're not letting yourself relax is what that means. So you're a little red blood cell. You delivered oxygen to the lower extremities. You're coming back to the right pump by way of the inferior vena cava. Now, if you had delivered it up to the hair follicles on the head or the fingertips, which way are you coming back to this heart? Superior vena cava. Either way, where are you right here at the number 1 position? Where are you? And I don't want y'all to name. Let me just say this: if you number these, I'm going to not give you any credit. You're going to list the structures that you enter and that you move past to get back to that same structure. Because you just told me that as a red blood cell, you go through the system for 120 days. You circulate. Did you say that? Mm-hmm. All right. So you're a red blood cell. You delivered oxygen to the system. You're coming back by way of either the inferior or superior vena cava, and now you're in the right, what? Atrium. Do you have a lot of oxygen on you, or do you have a lot of what? CO2. You have CO2 because you're on the right, you're coming back to the right pump. So this is the right atrium, you're in it. It contracts, right, Mariah? It contracts. And what do you pass, Mariah? You pass it. What is this valve called? The what kind? It's exactly right, tricuspid. Great. So right atrium, tricuspid. Now you're in what, Madeline? The right ventricle. Y'all like that? Megan, the right ventricle contracts and you pass by the what valve? Megan, right here. This, just look up here at this one. It's what valve is this? It's the pulmonary side, so it's the pulmonary valve. Pulmonary valve, okay, because it's the pulmonary circuit. The right side's the pulmonary circuit, right? So the pulmonary valve, and now you're in the pulmonary arteries. I don't care that you know pulmonary trunk. That's what I'm telling you. Don't memorize that thing in your book. Don't do it, because a couple of your editions have it wrong. I want you to look at me, and we'll do it again, but you're just listing structures, aren't you? So you're in the pulmonary arteries, and where are you being taken to? So write down lungs. From the pulmonary arteries, you go to the lungs. So I'm going to back up, just make sure everybody's got their list right. You've had inferior or superior vena cava, right atrium, tricuspid, right ventricle, pulmonary valve, pulmonary arteries, lungs. Did everybody have that? You want me to do it one more time? Yes. We're not finished. This is just beginning, but we're almost finished. I mean, we're all in the right time. Well, it's because I started you as a red blood cell coming back to the right pump. So that's where we started this time. Okay. And do we need to keep going until we get back there? Yeah. And then we just keep doing it for 120 days? Is that right? Yeah. So it's just that I'm starting here because your textbook kind of starts here. So, okay. So let me do it again. And y'all are just listing these structures. So inferior or superior vena cava, whichever way you delivered blood, oxygen the last time. Right atrium, tricuspid, right ventricle, pulmonary valve, pulmonary arteries, lungs. Are we good? We're getting there now. We understand it's a closed circuit, so we have to keep going until we get back to the what or what? Inferior, superior vena cava, don't we? Because we have to keep going. It's a closed circuit until we get back. By the way, though, what are we going to do as a red blood cell with the lungs? We're going to pick up oxygen and drop off what? Does that make good sense? Okay, so we're at the lungs, aren't we? But we got to now that we picked up oxygen, we got a job to do. What is that? We got to deliver that oxygen to the system. But what's going to help us to do that? The left pump, right? So we've got to get back to this left pump, and we're going to get there by way of pulmonary veins. So from the lungs, put pulmonary veins. They bring you to the left atrium. Pulmonary veins, left atrium. The left atrium contracts and you are passing by which valve? The lamb. Thank you. Put lamb, but y'all know what it means, don't you? Now you're in the where?
Left ventricle.
Left ventricle. The left ventricle contracts and what do you pass by?
The aortic valve.
Aortic valve. And now you're in the what?
Aortic.
Aorta, which is an artery, isn't it? It's a major artery, aorta. And now you're going to be delivered to the where? System. It might be the little toes, it might be the fingertips, it might be hair follicles, it might be wherever, but you're being delivered to the system, aren't you? From the system, what vessels will you end up coming back to the right side by way of? Either the inferior vena cava or the what?
Superior vena cava.
So let me tell you what your list should look like. This is a gimme quiz. It's really anatomy, isn't it? It's understanding that you know those structures that you either enter or you pass by on your way to get back to that starting point. It's a closed system. So let me give them to you again. You ready? Inferior or superior vena cava, right atrium, tricuspid, right ventricle, pulmonary valve, pulmonary arteries, lungs, pulmonary veins, left atrium, lamb. You know what lamb stands for? Good, okay. Left ventricle, aortic valve, aorta, system. And from the system, where are you back to?
Inferior or superior.
It's a closed system. Did everybody write your list? So you know your list, don't you? Do I want you to memorize that list?
No.
No. What do I want you to do? I want you to envision it. I want you to envision that this is how blood is flowing in your body. This is how blood is being sent to the lungs to pick up oxygen. This is how blood is being delivered to your tissues to drop off oxygen. This is the way blood moves through your body in a what? In a how many pump system? A 2-pump system. I want you to visualize this. Do you see now why it's important that you don't go backwards as a blood cell? You can't go backwards as a blood cell, or that's going to be putting burdens on either the system, the lungs, and those burdens are going to be, the burden is mostly going to be on the pumps, isn't it? So it's a closed system. Are you good? Are you good? Now, I want to bring your attention to this, and please pay attention to this, because again, this is where people make the most mistakes on understanding the anatomy of the heart. Why do we study anatomy along with physiology? Because what? The structure will dictate their functioning, what they're doing. And if you're trying to memorize them isolated, bless your hearts. Right? But I want you to pay attention to something. Well, first of all, the first thing that one of the biggest mistakes is that people will look at a heart or a structure and they confuse what is right and left. Whenever you're looking at somebody, when I'm looking at you, I could see through to your heart. I mean, I can't really do that. I'm not Superwoman, but I know your heart's like that, right? And I know that this is my right, but this is your right. So this is your right side of the heart and your left side of your heart. I'm looking at your heart. I have to know the right and left side. People get so confused. So make sure that you have that down, the right and left down. And don't think I'm saying just students do that. Physicians do that. Surgeons do that. You know, that's why they come in and see you before they have surgery and they put a little X saying, don't remove this eye, remove this one. That's actually been done. Did y'all know that? Where they've had to remove an eye because of cancer and they end up removing the healthy one. And guess what they end up having to do the next day? Go in and remove the cancerous one. And so now guess what your patient is? Blind. Completely. That's actually happened to eyes. It's happened to limbs. So you all, I'm not yelling at y'all because you're students to get this. This happens, but don't let it happen to you. Understand that when you're looking at a structure, what that structure's right is, and what that structure's left is. Yes, Charlie.
I used to do that when I was a treatment nurse.
You would write
I
on.
would go in and say, okay, I have to do the wound care on this side. And then as I come back in the room and the patient can turn, I'm like, oh my gosh.
Yeah.
I forgot what side I hate to do.
Yeah, you know, we all need to take a breath and think, you know, and remember things like this. That's the most often confused. But I will also tell you that what also gets confused is this. And see, don't let it, because I'm showing you this here. This pulmonary, and I know it's the pulmonary artery because it looks like it has a path to the right ventricle. So this must be the pulmonary artery. I didn't need it labeled. I knew that, right? Because it's going to this right ventricle. So this pulmonary artery, of course, you have two lungs. You have a what one and a what one. You have a right lung and you have a left lung. So of course, the pulmonary artery is either going to take blood to the right lung or the left lung. And you as a little red blood cell, you know, you might go this time to the right lung. The next time you might go to the left lung. But anyway, you're picking up oxygen either way, right? Correct? And then when you come back to this left atrium, these are veins. Y'all said veins bring blood to the heart. You might come back by the way of the right pulmonary veins, or you might be coming back by way of the left pulmonary veins. You get what I mean? Because obviously we have two lungs. So there's going to be a right pulmonary artery, and a left pulmonary artery, isn't it? Depending on which lung you're being sent to. And then coming back, same deal. So people will mistakenly label right and left wrong, and they'll mistakenly not know what veins and arteries. On a nursing exam question, the question was written incorrect because the question said that which vessels, the question was asking which vessels carry oxygenated blood, arteries or veins? Arteries. Little veins. But I want everybody thinking about this question. Which vessels carry oxygenated blood?
Arteries in the body, veins and the pulmonary.
Vessels and you got it right. And let me tell you, that wasn't one of the answers. The answers, they wanted arteries, but is that a good question? It actually makes you think they didn't know what they were talking about. Because obviously, the vessels that carry oxygenated blood to the system are going to be these arteries to the system, because this left side has oxygenated blood. But the pulmonary veins coming from the lungs, they have oxygenated blood too. So not all arteries carry oxygenated blood. Which arteries don't carry oxygenated blood?
Pulmonary.
The pulmonary arteries don't carry oxygenated blood. Do y'all get that?
Yeah.
That's one of those times when you read a question and you think, wait a minute, this is wrong. Because not all arteries carry oxygenated blood. Pulmonary arteries don't. Because pulmonary arteries are carrying the deoxygenated blood from the right pump to the lungs. They're taking it to the lungs so that the blood can then at the lungs do what? Pick up oxygen, right? Here's what those people who write those questions don't know. They don't know that the heart is a two-pump system. The pulmonary pump has deoxygenated blood. It's pushing that to the lungs to pick up oxygen. Then it comes back to the left pump so that the oxygenated blood can then be sent to the where? The system, which includes the heart itself, which means and those are by way of which special vessels carry oxygenated blood to the heart? Coronary arteries that nourish the heart. Right? All right, so take a quick break and come back. Like 5 minutes, 10 minutes, 5 minutes, 10 minutes, 10 minutes, 10 minutes. Okay.
I have to take this. I'm freaking out.
Has it been 10 minutes? I don't know.
I'm gonna call you if I have trouble.
Y'all good? Are we back? Yeah. All right. So this little thing I just gave you of imagining yourself as a red blood cell for 120 days moving through the system like this, that's going to be one quiz. So you will also have electric quiz. Okay, so the next time we move on anything we talked about today. So it's really just 2 opportunities, right? For lecture quizzes. Is that fair?
So this counts as a lecture, not a lab.
Dude, what do y'all want it? It's really anatomy. Y'all would prefer lab?
Yeah.
You want to have some lab quiz? The labs, it really is anatomy. So, okay, let's make it a lab quiz grade. Maybe some people have lower lab quiz grades. They want to bring that lab quiz, because remember, I don't drop any lab quiz grades. And it should be a gimme. People should get 100s on this. So let's make it a lab quiz grade. That's fine, I don't care. All right, so, guys, myocardial infarction and MI. Myocardial infarction. So we know what the myocardium is. What is the myocardium? It is that heart muscle. It is that muscle, the most intense tissue, right? So it is the muscle that's actually contracting, ejecting blood. So you can actually realize that if there's been a lack of blood supply to that muscle and that muscle dies, that is going to adversely affect how much blood can be ejected. You know, right? So myocardial infarction. Some myocardial infarction, and infarction just means a sudden loss of blood supply. Isn't that what that means? And that's anywhere. Anytime you hear that term, that could be to any tissue, but now we're talking about the heart, the myocardium. So an MI is what people call a heart attack. Do some people die of the first heart attack they ever had? Some people do. The thing is that it's getting early, quick treatment, right? Emergency treatment, because they can actually prevent some further damage after the initial heart attack is occurring. And then, you know, so emergency care is going to be the vital thing that happens here. And it would certainly depend on how much of the heart wall is affected, the myocardium is affected as far as prognosis of how well the person will end up doing. I had talked to you about all that. Now we remember, maybe some of you remember the histology lab where you had to identify cardiac muscle versus skeletal versus smooth. Some of you kind of remember this histology slide of the stained cardiac muscle. Cardiac muscle has to have aerobic constant oxygen supply. It's not like your skeletal muscles where if you're running from a bull, you can actually you know, you can get to a part where you're not even breathing, and you can go for a short period of time into anaerobic fermentation. The heart's not like that. It's got to have a constant oxygen supply, so aerobic respiration. It's got a lot of myoglobin and glycogen. What did we remember glycogen is a storage molecule of? Glucose, which is our first reactant in aerobic respiration. What is this protein, myoglobin? Have you ever heard of myoglobin? It is a protein that, what'd you say? Nicole? Yeah.
Oh, it's just the proteins in the muscle, right?
It's a protein in the muscle that is going to actually store a little bit of oxygen. So it's going to be sort of a backup, a little bit of a backup for oxygen as well. So in this muscle, you have stored glucose and stored oxygen, but you also don't want to have interrupted blood supply, do you? Because that's going to lead to an infarction, and that's not going to be good. Now, the heart itself, I want you to think about how electricity moves through the heart. You guys had learned from before you got in here with me, skeletal muscle has to be innervated by motor neurons. You can voluntarily think to yourself, walk across a room, and you're sending signals by way of motor neurons talking to skeletal muscles for you to move. It's voluntary. But the heart is autorhythmic. And if y'all remember, I told you that the heart has a pacemaker that's in the heart. Do y'all remember that? Yeah. And the pacemaker in the heart is something that's called the SA node. You would need to know exactly what SA stands for. It's the sinoatrial node. And it's this little group of cells have one function and one function only. And they start their function before the 8th week of an embryo. And that function is to fire an electrical spark. And it's quicker than that. I just can't snap any faster than that. So this little group of cells that's referred to as the SA node, the sinoatrial node, is the pacemaker of the heart because it's sending out an electrical fire at a very rhythmic rate. Now, do you think that electrical signal just dies right here? No. And y'all told me this right atrium is really kissing walls. It's sharing a wall with the what? The left atrium. Y'all said that, right? Correct. So what happens right here in the sinoatrial node, when it sends out an electrical shock, that immediately goes to the left one. That's immediately received, and the right and the left at the same time. Did I tell you the pumps are working in synchrony? I did, didn't I? Okay. So this sinoatrial node sends out a signal. The atria get that signal. They get that signal. And what's it going to cause the atria to do? Contract. Now look, when they get that signal, this signal is then going to be sent to what's called an AV node. Why do you think it's called the AV node? Because it's actually sitting right here between the what and the what? The atria and the ventricles. So it's called an AV node. And then that's going to send that electric shock down through what's called these bundle branches that split out and are encapsulating the what chambers? The ventricles. These are called Purkinje fibers that are in the ventricle. And then the ventricles are going to eventually do what? Does that make sense? Yeah. And let me tell you where you got it, okay? It's in text right here. So the SA node is the pacemaker that initiates this heart rate, sending the signal to the AV. Look, guys, it's by text too, abbreviated, and this is all in your textbook too. The AV node, which then sends it to the bundle, which then sends it to the branches of the ventricles. Let me tell you what I think is the easiest place to see it. Are y'all ready to see this? All right. Wait a minute. Before I do, let me give you a couple of definitions. Let me give you a definition for systole, some people say, and diastole or diastole. Okay, so systole or diastole, or systole or diastole. You'll hear them both. But anyway, this is actually, systole is going to be contraction. That when you hear that word, you know that what's happened? You know contractions happen there. And diastole or diastole is going to be what? Relaxation. Relaxation. So relaxation. Okay? So you've got to kind of know that. And then when you hear about rhythm, like heart rhythms, it means that you're expecting it at exact intervals, right? Boom, 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 right? Not boom, 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 boom. You know, it's not something crazy. It's exact rhythms. So what would arrhythmia mean? You don't have that. Some's good, some's off. So you're not getting these exact rhythms. Why do we want exact rhythms? Because the rhythm of the heart allows for the heart muscle to relax in between. It's a built-in refractory period for this muscle that we call the heart. And it's built in, and that helps the heart to keep going when that's happening. When it's out of rhythm, this can indicate a very serious situation, right? So now that we know the definitions of those, let me tell you how we can measure how the electricity moves through the heart. It's called an ECG. You probably have heard of it as an EKG, haven't you? Either one are acceptable, but people call it an EKG because of the German spelling of cardiogram. The German European spelling often C's and K's are interchanged. And so y'all have all probably heard it as an EKG, but it's an ECG. It's an electrocardiogram. And make sure you know that that's what it stands for, okay? Now, most of you all have actually seen, I don't care if it's on TV, y'all have seen ECGs, haven't you? And you understand that you're seeing a monitor maybe where this little rhythm is getting repeated, right? And you're seeing it repeated at very precise intervals, correct? Maybe some of you even seen a tape, right? An ECG tape on paper, and you're seeing it's printed out. You can see the ECG at these very, very precise intervals. You've seen this type of pattern repeated, right? Now let me tell you what they stand for, and this is where I think is the best slide, and I don't know what number that is, but y'all could refer to it, number 29. I think this slide kind of shows it the nicest, because we said that with every heart rhythm, boom, 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 with every one of those boom, booms, we should see something that looks like this on an ECG. And I'm going to tell you what these little bleeps correlate with, and you would need to know the basics of this. The first little bleep that you notice is called a P wave. And that P wave, you're going to want to see it because it means that you are actually seeing and detecting when the SA node fires. So that SA node fired. And you're seeing it right here. And what do you know is going to be initiated from that? Contraction of the what? The atria. The atria are contracting here. Now, then you're going to see something that looks like this. It's called a QRS complex. And what do we know? That the SA node fired and it sent a signal to the AV node, right? You're going to see this on the QRS complex. You're going to see the AV nodes firing. The ventricles are now going to be getting their signal to contract. And what are the atria going to be doing? No, relaxing. They're going to be relaxing, but the ventricles are going to start their contraction. And then during this T wave, the ventricles are going to stop their contraction. They're going to end up repolarizing and starting to relax. And you've got this refractory period that happens before the next one occurs. You get what I mean? Everybody get that? So now when we look at a ECG, a normal one, we know that we want to have very rhythmic patterns that look P, QRS, and what was this? T. And we want to see those repeated. Now, if we count from one point to the next point that it gets to there, can we actually extrapolate that, how many beats per minute there are for heart rate? Yeah, because when we think about heart rate, and y'all would want to know, that's beats per minute, isn't it? So when we look at an ECG and we look at this pattern, and know how long it takes for one rhythm, then we know that in a minute, that's going to be beats per minute. What is a normal resting heart rate for an adult? It can be from 60 beats per minute to 100 beats per minute. That can be normal for an adult. So some adults are going to have a pretty low resting heart rate. Some adults are going to have a normal higher resting heart rate, and that might be normal for them. Now, where do most people fall though? In the 70s, 70 to 82 or so. Most people really fall in there. But it's going to depend on something else. We're going to talk about it in just a minute, what might be normal for them. But some people really have a really low resting heart rate. All right, so, and y'all know that this is how many rhythms there are per minute, beats per minute, right? All right, now, you have any questions for me so far? So you can sort of see, again, this is another great slide to sort of see. So the P wave showed that the SA node fired, and here you're seeing the contraction of the atria because they got their signal to contract. The AB node fired, and the ventricles are getting their signal to contract, and then the ventricles are going to start to do what? Relax. Is that right? And that's what you want to see. All right. There's all kinds of pictures you can look at. Now look, I'm not a cardiologist, and I don't know, all these, but like cardiac techs, cardiologists, obviously this is there, and cardiac techs, the diagnostic value is so important to these. And y'all, how many of you had an EKG and ECG? How many of you? Yeah, so it's an easy test to do, isn't it? And to get on a patient. And somebody who knows what they're doing, they can really tell so much about those patterns. I can tell when it's not normal, when there's no P, QRS, or T, or when things are not normal. But cardiologists, this is really valuable to them, and cardiac techs, because they learn there's more than 100 different patterns that they have to learn. The cardiac techs have to learn for their passing their thing. Have you seen those books? Have you seen them, Julie? It's pretty amazing. It's a lot of them. And they'll look at the patterns and they'll say, oh, they're low on this electrolyte, or they're low on this, or this is indicating, a block here, or block. And it's a lot of different things that they can, that they end up telling from this. So it's an important diagnostic test, right? So when we look at a normal, we could probably, even all of us at this point would see, okay, I like this one, but something's wrong right here. Something looks obviously wrong right here. And what this is wrong is there are no P waves. Now this isn't exactly true. It's just that it's not picking up. But when that happens and the atria are not getting a good signal, if the atria are not sending enough blood to the ventricles, are the ventricles going to be not sending enough blood out? No, so it's going to affect the whole thing. This is what we can end up calling AFib. Have you heard of AFib? Y'all probably all heard of that. Fibrillation. So the atria are really not doing their job. People can live in this for quite a long time, depending on the severity of it, and certainly treatments can help with this, help the blood circulation. So, but this is obviously, you would look at this and think, okay, well, something's wrong with that. There's others that you would notice right away. You would notice something at this inverted QRS. This is called a PVC, premature ventricular contraction, a PVC. Have y'all heard those? People, it's actually normal to have some of those, but you shouldn't be having too many of those. And some people actually really feel it when they have those. So some people tell you that they'll feel like their heart flipped over, or they'll feel like they had a big flutter in their heart, and it was a PVC. So it's normal. It's actually, let me tell you again, it can be normal to have those. That can happen, but you really wouldn't want to be having a lot of those, or you would need to have them checked out, right? Anybody here have PVCs? Nobody? So, okay. So you can also see someone who has an AB block, because this is a normal, the heart did just what it was supposed to do right here, did just what it was supposed to do right here, But every now and then the AV is blocked. So what this is telling you, this is actually more serious even than AFib, because if the ventricles are not doing what they're supposed to be doing, that means blood is really not getting out, right? So this is an AV node blockage failure here, and certainly, again, needs to be addressed by a cardiologist. When you see something like this, the heart's not pumping at all. It's just kind of doing this, no pumping's happening. This is fibrillation, so what do you need? You need an emergency person. You need somebody who knows how to do something to help you change. Because this is like within minutes, is this person gone? Yeah. So this has happened. All right, now, so what this is saying to you is that in a cardiac cycle, we'll have the atria contracting while the ventricles are relaxed to receive the blood. Is that right? And then we have the atria relaxing when the ventricles are contracting and sending blood out to the arteries. Is that right? Does that make sense? And then there's this quiet period. So have I already told you what the heart sounds are? I've already told you what the heart sounds are, and you do need to know. It's not the opening of the valves. You wouldn't hear that. What is it? It's the slamming shut of first the which set of valves, and then the second sound is from the slamming shut of these. And you actually know the names of the AV now, and you know the names of the semi-litter. Okay, good, good. That's called progress. All right. So now I want to talk to you about something called cardiac output. And I want y'all to know that cardiac output, what do you think cardiac output is related to? What do you think it's related to?
Blood.
What'd you say? Cardiac. Yeah, it's just telling you how much blood is being pumped by the heart. And let me tell you what cardiac output, how it's determined. It's determined by something called stroke volume, which is really ejection fraction, stroke volume, times your heart rate. How do we get heart rates again? I mean, if we don't have ECG machines, what can we just do?
Count for a minute.
Yeah, you count for a full minute, don't you? No matter what somebody tells you, you count. Why do you count for a full minute? Why couldn't you count for just 15 seconds and multiply that by 4? Because you can't feel the arrhythmias and you wouldn't know it, and you could not pick that up, right? You do for a full minute, or you have an ECG hooked up and that'll kind of tell you. So that's even easier, and that's probably more accurate, way more accurate, right? But anyway, so CO, cardiac output, is equal to heart rate times SV, stroke volume. And I'm about to tell you what stroke volume is related to. Okay, and cardiologists do these tests, and you know, they're going to end up figuring this out. All right, now look. Stroke volume is just related to how much blood, literally in milliliters, is leaving the heart with each ventricular contraction. How much blood is being ejected? And then over a minute's time, that's telling you what your cardiac output is. Now look, in an average sized person, adult, do bigger people have bigger hearts? Do they? They do. Bigger people have bigger hearts. Little bitty people have smaller little hearts, right? But on an average stroke volume in a healthy heart is about 70 milliliters. Now, I'm not going to even ask you that because it's going to depend on your patient, their size, their age. It's going to depend on the patient. But depending on the patient's demographics, meaning their size, their age, their whatever, you're going to want to see it. You're going to have tables that tell you what Julie should be putting out with each stroke, each ejection, right? So we're going to know what she should be doing. And cardiac output can be measured with a person at rest, but also a person who's exercising or being asked to do something. Now, what you would really like to see, and this is called cardiac reserve. cardiac reserve. What you would really like to see is a big difference between somebody's at rest cardiac output and their exercise cardiac output. You'd like to be able to see that their heart can put out more if the body is demanding it. And that difference is when you refer to cardiac reserve, the difference in the cardiac output at rest and in activity. So if you have a patient who's on their chart, you see that they have minimum to no cardiac reserve. Are you going to ask them to go to the bathroom on their own? Are you going to get them to walk to the bathroom on their own? Are you going to tell them, walking's good for you, why don't you walk down the hall today? Why not?
There's not a big difference between what
There's not, they have very little cardiac reserve, and you getting them to do anything like that could actually cause them to go into cardiac arrest. Is everybody good with that? Okay, so you'll know when you see that on a patient's chart, this person has cardiovascular disease, their cardiac reserve is minimum, because the cardiac output is minimum, and you're gonna tell them things like, even when they're defecating or urinating, don't put a big strain on the abdomen, because when you do, you're releasing more acetylcholine, and that's slowing your heart rate down too much. You're not going to have them, even if you're helping them, go to the back. You're going to be very careful with letting them know what they can do. Okay? Now, great. That's all I want you to know. All right, so that's that. So, how many pumps? Two pumps. How many? You cannot understand a cardiovascular system and a respiratory system unless you understand that. Two pumps. They've got to be working in synchrony. We know the right side shouldn't be pumping as hard to the lungs because it's not as far away, right? But the balance has to be just perfect. If you've ever heard of congestive heart disease or failure, have you heard of CHD or CHF? Y'all would know what that stands for now? Congestive heart disease, congestive heart failure. This is when the two ventricles, the two pumps, are not working in synchrony. It doesn't mean that they aren't going to be pumping at the same time. They are, but they're not pumping effectively at equal. So let me tell you what happens and see if this doesn't make sense. When the right ventricle output is exceeding over the left, would it make sense to you that if it's working harder, and it might be having to work harder because of respiratory disease, what is it giving blood more time to do as it's moving through this area? It's giving the water and the blood plasma more time to move into the pleural tissue. And so what have you now got? What kind of edema? Pulmonary edema. Right? Okay, so then when you have the left side that is now exceeding what the right can do, what do you have here? Systemic edema. Systemic edema. You get that? So we want that circle that y'all are doing for me of a little red blood cell, you want to be absolutely paced. If you're running through one of them faster than you run through the other one, is that going to be a problem? You want it to be balanced. It's got to be balanced. Yes.
So pulmonary edema is when the right ventricle is pumping more than the left ventricle.
Yes.
And systemic edema is when the left ventricle is pumping more out than the right ventricle.
The left output exceeds the right output. Yeah. Okay. So, and I told you what cardiac output meant. It means heart rate times the stroke volume, which is just how much is being injected, right? And you don't have to know numbers. I'm not going to ask you numbers. But the main thing about knowing cardiac output is that you understand it's different when you're at rest than it is when you are doing something. And it should be. And it needs to be. And the more difference it can be, the healthier the person is, right? So if the cardiac reserve is great, then it means that this person's going to be more fit. Usually with it, looking at somebody who's more fit. And it's going to decrease with disease, and it decreases with some of the age. Why?
Ability to move around.
Well, because people are typically become a little bit less active. Staying active can really help to maintain this, and this is why activity is so, why do I say that? But anyway, so staying active. But because as we age though, isn't it natural to lose some of the elasticity of the lungs? Is that natural? Is it natural that we're not, jumping fences and chasing ducks and, doing what you did? Don't say you didn't do that. If you didn't do that, you didn't have a job to do. So anyway, I actually didn't chase ducks because the ducks that were many. That's true story. So anyway, but so we start to do less, and then that's going to end up, that's a natural part of it. It really is a natural part of aging. But there are things that we can do to slow it down, things that we can do to help to maintain. And mostly it's just by doing what? Just staying active. And, just by staying active and moving around. All right, so heart rate. I had told you all normal heart rates, right? It really can be from 60 to 100. If it's higher than 100 at rest, this is referred to as tachycardia. Everybody say that. Tachycardia. And then bradycardia is going to be lower, persisting lower than 60. Some people have normal lower than 60, but that's pretty low, right? So anyway, so if somebody is in the tachycardic range or too low, then usually they're going to want to do some workups and see why that is. This is for adults. What do we know about kids? Completely different. Completely different beast. They have a higher heart rate. I want y'all to know two terms, and it's weird the way they do them in your book, so I want to let you know what they really mean. I want you to know two terms. I want you to know chronotropic and ionotropic versus ionotropic. Chronotropic effect versus ionotropic effect. You ready? If something has a positive chronotropic effect, it means it's going to increase your heart rate. If it has a negative chronotropic effect, what's it going to do? Decrease your heart rate. Decrease your heart rate. If something has a positive ionotropic effect, this is different than heart rate. It's going to enhance the intensity of the beat. Because you said, how was it beating, right? It was beating, right? And that's a normal beating, but all of a sudden now it's doing what? Harder, right? So, exactly. So, ionotropic is the contraction strength. Thank you, Charlene. Where if you had a negative ionotropic effect, it would mean it would relax the heart. Beta blockers. What do beta blockers do to heart rate and heart contraction strength too? What do they do? They slow it down, don't they? So they end up slowing that down, the heart rate and the heart contraction strength. So what they end up doing, beta blockers, is they actually interfere. Well, not interfere. I mean, they're giving us medication, but they interfere with the receptors for the sympathetic nervous system. And what does the sympathetic nervous system give out? Epinephrine. Thank you. Norepinephrine. Yeah, and what do they do when they get to the heart? They increase the heart rate and they increase the contraction strength. So beta blockers are going to end up sitting on those receptors so that the sympathetic nervous system can't have as much of an effect. So we're just going to calm it down. Okay. The reason I want you to know these is because when you all have patients, and believe me, you will save, if you do any kind of emergency care, certainly if you do med-surg care, or anyway, you'll save some patients on this because it'll be missed until it gets to you. You'll have to, your patients, you have to know what meds they're on. And you've got a patient that you're doing vital signs on 3 times a day or more, depending on what's going on with them. But you're doing the vital signs and you see they have a really low heart rate. And they're put on a drug that slows their heart rate down. And you might be thinking to yourself, well, this drug is slowing their heart rate down. This isn't just there. This is what the drug is doing. but it might not be. If it's too slow, you've got to figure out if that patient was put on something they shouldn't have been. That happened to my dad. My dad had a normal resting heart rate in the 40s. That was normal for him. He was a big man, had a big stroke volume. He didn't need many beats per minute. He was very incredibly healthy, right? Athletes have really low heart rates. His heart rate his whole life had been in his 40s. And so he gets to be in his 80s, and yes, he's beginning with some cardiovascular, mostly vascular, disease. And a cardiologist put him on a negative chronotropic drug. And what did it do to his heart rate? It dropped it into the 30s. And I'm going to tell you something, he was ready for his heart to stop. So it took another physician to catch that. And that physician was pissed. I can tell you, was mad. And so Dad had to go in just for one event. He had to go into the ICU for about a week until that drug got out of the system. And he was in ICU only because his heart rate was so low that at any minute, what could happen? It could have stopped. So please pay attention. So pay attention to drugs and what their interactions are. And if you're thinking something just doesn't look right, question it, and help, because that happens. So these are, and y'all know, any of my nurses know, when you're in nursing school, for all of your patients, you have to know all of the drugs that they're on and all of the actions of the drugs and the side effects and all the things that, whatever. Because when somebody gets a medication, is it going to have some side effects? It is. And then sometimes they're given a medication for the side effects, right? And then that medication is going to have some stuff. And then you got to know them all, right? Everything's going. So it's like juggling, but important thing to do. All right, so sympathetic nervous system speeds up positive chronotropic and ionotropic effects. Parasympathetic system has the negative of that. So it has the negative, and we know mostly because of the vagus nerve sending out acetylcholine slows the heart rate down, doesn't it? So we know what the normal systems do, don't you? Right? All right. And we know higher brain systems actually affect too. So for example, do emotions change your heart rate? All those things do. So we absolutely know, but we have built-in mechanisms too. So we have these baroreceptors on our arteries that are going to measure stretch. These baroreceptors measure stretch on the arteries. So if the arteries seem like they're being stretched, which means that the heart is pushing too hard and blood is coming into them too much, then what can happen is a signal will get sent to slow that down, right? And do that. So we have these built-in mechanisms of the autonomic nervous system that are controlling, because does our heart rate and our heart contraction rate, does it in homeostasis go up and down, depending on what we need happen, right? So that's a normal thing that is actually happening. We have chemoreceptors that are measuring chemicals like CO2 and oxygen and other chemicals in the body. pH levels are being measured. So all of these play a role in what is actually happening. Does exercise help us? Mm-hmm. Yes. So it's really going to help us. It's going to help us with that cardiac reserve difference between rest and exercise. Arteriosclerosis. This is going to be hardening. Sclerosis means hardening, doesn't it? This is what this term means. This is going to be hardening of the arteries. And what is happening in this particular situation is you've got a blood vessel. I want everybody to think of like an artery. Like if I had a section of an artery right here, and I did a transverse cut of it. This is and it's then stained it. This is what a normal one would look like. A normal one would be a person. But whatever. If you looked at a histology slide. So in the center here, what's filling this? Blood. And we know there's an inner endothelial lining, but the middle layer is muscle, which is the arterial wall. And arteries have to withstand a ton of pressure, right? So we know it's a thick muscle wall, and then there's this outer wall, you know, so it's distinct 3 layers of tissues for you, and this is a normal looking one. But look at this one. This is what you see when somebody said that they had a 90% blockage. This is about what it would look like. Is that just crazy? But what happens here is that plaque formation, which can be composed of cholesterol, platelets, and other cellular debris, it can actually get, as those are laying down on a healthy wall, it can sort of split this inner lining, and it can build up and push this lining closed. So now it's like it's all blocked up, isn't it? And so now this is the only way blood is getting through right there. So that doesn't look good, does it? Mm-hmm. Yeah.
So what do you do for that?
So what that probably was from somebody who died from that, right? Leading to cardiovascular disease. Cardiovascular disease, which usually this contributes to, kill about, and your textbook says this, and it hasn't changed much in the last couple of years, about 650,000 Americans a year. That's a lot, isn't it? That's a whole lot. Now, so what you do is try to be proactive, and people get their cholesterols checked, don't they? Smoking contributes to this. Cholesterol, high cholesterol levels contribute to this. High triglycerides contribute to this. Inactive lifestyles contribute to this. So if it's already kind of advanced, though, other than bypasses, like coronary bypasses, there's not a lot you can do. But these vessels can actually be even the aorta, the descending aorta. You know, the aorta is taking blood from the left pump to the system. And that major aorta does this little turn thing. So it's got, it's called an aortic arch. And there's vessels coming off the aorta. So the ones that are near the top are sending blood to the upper regions. But then the descending aorta is branching off and sending blood to the lower areas, right? And the aorta has a ton of pressure associated with it. So as it loses its rebound ability, because it's hardening and stiffening, it can actually just rupture. There's a scale, it's a European scale, I think it's still like 0 to 7, 7 being the worst, where how hard the arteries are. And I saw an autopsy once where a person had died of arteriosclerosis. And the descending aorta, and this person had just died that week, but the descending aorta, if you touched it, it cracked, just like crackling does. Your arteries should be like rubber thick tubes. They feel so, your arteries are really, they're not like little veins. They're really thick, they're rubbery, you know, and they have bounce back, right? But you could touch this person's aorta and it just cracked. Mm-hmm. It was at the 7 on the scale, it was the highest. I don't know how they live that long, right? Yeah.
So epinephrine and norepinephrine, they target. Yes, they target the smooth muscle on the veins.
I have to double check, right?
Is that
they're targeting cardiovascular and the vessels as well. Vessels contract and the heart beats faster and harder.
The muscle part that you talked about? You said it has an epithelial layer and then a muscle wall. Is that where it's targeting, or like is that where that hormone kind of goes in?
So on vessels,
yes.
Yeah. So it targets smooth muscles to contract.
Is that on the outer? Like I'm trying to like visualize.
No,
where
it's actually in the bloodstream and the muscles.
Okay.
So it's contract. It's there. These linings are endothelial linings. They're epithelial linings. The muscle is contracting in response to the smooth
That's
muscle.
what I meant. Like if that, looking at it, that's where that would
Be targeting.
Yes, ma'am.
Yeah, because blood supply is coming here and they get it, and it's bringing that.
Yeah.
So they end up contracting in response to that.
Okay. Just getting a little bit of that anatomy of those.
Yeah,
things,
it's just a lot going on in it. So but we know that at the same time, that this is actually, these things, what are they doing to your airways?
Does it make it smaller?
The airways, depending on the target site, the airways are actually opening up with epinephrine because you're needing more oxygen coming in. So this is why we can give epinephrine if somebody's airways are what? Reacting to something, whether it's allergens or what it might be, and somebody's airways are closing. We can give epinephrine, but when we give epinephrine to somebody to get them an airway going, because we can see the airways are reactive, what do we have to watch for? Exactly.
Is
Blood
that
pressure
the EpiPen?
and yes.
Oh, okay.
Yes, you have to, it's not just a, oh, let's give this shot of epinephrine. You don't want somebody there with you that knows what they're doing because they need to be watching the cardiovascular system at the same time. All right, so you guys, this is the heart. How you feel about it? Super good. Fun. All right, so I am going to lecture on some vessels. Do y'all want to break now or break just between it? Want to just a break? So how about like 7 minutes? We'll say 20 after we'll come back. 7 minutes. 7 minutes. Time it. Here's the clock. That will help your study because you know by now that these tests that if I haven't said and talked about it, or it's an insight or disorder, then I'm not asking, right? So you know how to direct your study with these. In this chapter, I kind of hit the highlights, is what I'm saying. All right, so the vessels. So we certainly get this idea. I told you about this closed system that we have going, right? So we have the left side of the heart being the systemic circuit, sending blood out to the system and delivering oxygen, delivering nutrients, delivering all that, picking up waste product, and then coming back to the right pulmonary circuit to be sent to the lungs to do it again. Right? Excuse me. Okay, good. So when I was talking about the closed system, that included vessels. And not all vessels are created equal, which hopefully, you'll see in a second. But the heart, the pump itself, pumping blood out directly to arteries. How many of y'all have ever worked with pumps before? Like water irrigation systems or whatever. Any kind of pump. Nobody? Nobody in this room?
Yes.
Okay, who? Okay, a few people. Well, maybe you'll take our word for this. Where you are close to the pump and there's a lot of force coming from that pump, those pipes have to be thick and strong, really strong, because there's a lot of force being put on them close to the pump. But as you get further away from the pump, the pressure goes what? Down. So like, I think about the water irrigation pipes, and you got the tractor, which is pumping at the pond, and those pipes are big and thick. They really are, and they're heavy to carry, take my word for it. And so, but you get closer to the fields, and the pipes are getting thinner, smaller, and lighter. And then finally, you're at sprinkler heads, and they're pretty small by then, because the pressure's going down. It's enough pressure that the water's feeding to the field and out, but the pressure's going down the further you get from the pump. It's the same with our vessels. So these arteries that are close, these really large arteries that break off to medium-sized arteries, that break off to small arteries. Are we good? Everybody's good? These, and then finally to large arterioles, medium arterioles, to really tiny small arterioles, because they're breaking off. They're getting less thick and less strong as they go because the pressure's going what? Down. Finally, you're in these capillary beds. And these capillary beds, the pressure's low, has to be low enough that it's not going to rupture the capillaries. Because these capillary beds where all the exchange is occurring, and you would need to know it's at the capillary level, that diffusion of solids is happening and osmosis is happening. What is osmosis? Movement of water between two areas. Diffusion is the movement of what? Solutes, which are gases and nutrients and all kinds of, other things. So that's happening at this capillary level. The pressure has to be low there, low enough that it's not going to rupture the capillaries, but high enough that the blood keeps moving. Is that right? So I want you to think about that balance. It's pretty amazing, actually. So it has to be high enough that it keeps moving because it's going to move from capillaries into small venules, then to medium-sized venules, then to large venules, from the large venules to small veins, to medium-sized veins, to large veins, the largest ones being the what? Inferior or the superior vena cava, whichever one. Does that just make perfect sense to y'all? Okay, good. Because that's how blood is flowing to these things. And that's how the pressure has to be. What happens if blood slows down too much? It'll start to do that. Well, it could start to clot, couldn't it? It could start to clot. If the pressure's too low, there could be a signal. The blood is having, if the pressure is getting too low, the heart's going to try to work harder to push it, right? But then, so it's usually going to be beating faster. But then it'll get a signal to just do what? Stop. So it has to be just right. If anybody wants to contribute something as we go along, because I know I have nurses and people who have a lot of experience with emergency medicine. So if you have something you want to add, please just do it at this time. Now we also know that the vessel's integrity needs to be maintained, because does anybody know what it's called if you have a weak part of a vessel? And we said these arteries have a really thick muscle wall, don't they? Mm-hmm. But that they're also lined on the inside and they're lined on the outside. Does anybody know when the muscle wall is weakened and with each pump of the heart, each beat of that left ventricle, blood is pushing, pushing, pushing? Does anybody know what it's called when there's a weak, almost like blister area on a vessel, and the blister can get bigger and bigger and bigger until it ruptures? Do you know what that's called, a weakened vessel wall? It's called an aneurysm. It's called an aneurysm. That's exactly right. And the risk of the aneurysm, now many people have aneurysms that are never going to get any much bigger or cause any trouble. But what's the risk of an aneurysm? That it ruptures. And it's not just cerebral aneurysms. You can have aortic aneurysms, femoral artery aneurysms. So it can be anywhere in the body. The closer it is to the pump, the what? The closer it is to the pump, it's going to be the more immediate death if it ruptures. But if it's in a structure like the brain, the cerebral aneurysm, can that be immediate death too? Yes. Yes, absolutely. Because what's controlling our world? Our central nervous system, right? Our brain is. So aneurysm is a weakened vessel wall that has a risk of rupturing. People who have survived aneurysm rupturings are very, very, very lucky people. Yes. So an abdominal aortic aneurysm is, we know the aorta, taking from the left systemic side, is going to the aorta. This aorta has an arch here. If blood goes out of these structures, it's going to the upper area of the body to deliver. But most of it actually takes a turn here, an arch. And this descending, this is called the descending aorta, comes all the way down through the abdominal region, splits off at what's called the iliac. Why would that be called the iliac? Yeah, because of that whole region is the iliac region. It breaks off there, and then the femoral artery, right? But in this descending aorta, there's a ton of pressure on that aorta. And some people have an aortic aneurysm. And most people who have them don't know they have them. But if they found out the person has them because of something else, and they've done scans, and they're like, oh, there's an aortic aneurysm. There's an abdominal aortic aneurysm. They'll watch it. If it gets over a bigger, they usually measure it, and if it gets over a particular size, they're usually going to go in and try to repair it. But they don't go in unless they think they see it getting bigger. Because, it's tricky. Yes.
Just a couple of weeks ago, I had a resident where I work at. She kept complaining of acid reflux, and it was just hurting me. Took her to the hospital twice. Said that it was just acid reflux.
She just
I don't know what happened for her. They had to go back to the hospital, and they took her to a different hospital and found out that she had an aneurysm, and it was too late.
That's awful. I'm sorry. But what can happen too, because you all understand, this is the pump. So does this take, I have to withstand a ton of pressure.
Yeah.
And there's something called a dissected aorta that can happen. And you know your heart's right here. So this is why they tell people if they have chest pain, you want to rule out what? Heart attack. Or if you think you've had acid reflux, well, you want to really rule out that it's something with the heart. But what can also happen is that this aorta can rupture here, and usually it's just minutes when that happens. We're talking like 2 minutes.
My uncle actually just survived one. But
He survived which type of aneurysm?
I don't know, but all I know is he goes out every Friday night to like the same bar, and he thought somebody slipped something into his drink, and that's why he went to the hospital.
And they found it before it ruptured.
All I know, he was in the ICU for like 2 weeks.
2 weeks. Wow. Wow. So I was thinking something that was inappropriate, so I'm going to second. I hope he's back with me. He wants to be doing. And it's lucky when you find them. When people find them, it's really lucky. Usually, if it's an aortic aneurysm that ruptures, the person doesn't survive. Usually, they don't survive that.
I worked with a girl who had one in her head, and she was at work, and it ruptured while she was at work, and she survived. She survived it, but she has to have chronic shots because she has chronic migraines. She's got shunts, and she's worth $1 million. But she had a lot of surgeries. But she was in the hospital for like months.
The people who survive cerebral aneurysms will usually tell you, people who don't survive them tell you, but the people who survive tell you that it's like a headache magnified times 1,000. So it's not like, somebody who thinks they have a headache or migraine even. It's like, it's incapacitating, the pain.
Does that affect the way that they think? Because
Oh,
I
yeah.
remember one of my friends in high school, her mom had it, and she was a professor, and she had to stop. And she's funny though. She goes, "Oh, it's my aneurysm." Like she just knows that she's like a little wacky because of it. She knows. She's like, because of what happened, so she had to stop because of it.
Really? So, yeah. So controlling blood pressure, somebody has a known aneurysm and they're just watching it or whatever. And obviously they want to make sure that their blood pressure stays maintained, and, weight can play a role, especially abdominal aneurysms, the pressure. So just all kinds of things they might want to try to get people to do or not do, stop doing, while they're watching it. And then, like I said, if it gets over a certain size, they'll go ahead and surgically repair it. I don't know how true this is, but I have seen that if we scanned all people, at a certain age, we scan them, it's probably about 1/4 of the population that we have aneurysm that are never going to do anything. They're never going to get worse. They're not in a place that's going to make it. What are you laughing at?
I'm sorry. I had to. Go ahead. I wasn't trying to interrupt. I just happened to look at the next slide, and it correlated with what I was going to ask, and yeah, that's all.
Okay. So anyway, just because you hear it, I don't want anybody panicking over a loved one or a patient, because we just said that many people don't survive on rupturing. It's kind of true they don't survive on rupturing, but they can survive the having them. They just, or depending on how slow the leakage is from the rupturing, it can sometimes, and where an aneurysm is, they can survive it sometimes. But when it's that close to the heart, like the descending aorta, it's not usually something they survive. Or dissecting aorta. Who was the guy from Three's Company? Y'all don't even remember Three's Company? Do you? Okay. What was his name? John or something? He died from that. He died from that. And so, and he was there. He was in the medical facility. I think he got there to the medical facility, but still it happened. And it can happen right there in a hospital, and I'm talking about like 2 minutes, it's all you get. And usually you can't stop it unless somebody can, again, that they would have to crack you open for that. women can sometimes have them when they're delivering if they don't know. So this is like Marfan. Y'all have heard, remember Marfan syndrome? The thing that you worry about with Marfan syndrome isn't that the person's tall or double jointed. You worry because the aorta is weakened, and they can die from a bisected or dissected aorta. That's what they call it.
The basketball player guys.
Yeah, you'll hear about people with Marfan dying suddenly from a heart-related event, and it's usually that. It's usually the aorta. Okay, so what were you laughing at?
I was going to ask if there was if you had an aneurysm for a longer period of time, if your body could like
Anastomose?
Yeah, that's what I was thinking.
And then this next slide was kind of whatever. It's not usually, that's not usually how we think about with aneurysms. It's not why some people survive, it's just that theirs is never going to get worse. But we do have other, maybe it makes sense to you too, especially like in the liver. Your blood doesn't always have to be flowing at all sites at all the same pace always. Your blood is going to be directed to where you need it most at any given time, right? You get what I'm saying? So if you're in a fight or flight response, your blood is not going to be circulating well to your intestines. It's going to be going to where? It's going to be going to these muscles that you need to either run or you need to stay and fight, right? And some people actually freeze. But so that's where it needs to be. It's not going to be going. So these are just different ways that the blood kind of moves through, and hopefully that makes sense. I wish they drew these a little bit better, but you can see the difference. We said arteries are going to have with more pressure because they're the ones where blood's being taken away from the pump. And by the time it goes through capillary beds and get back to the veins, do veins need as thick of a muscle wall? Now, veins don't have typically, and that's the middle layer wall, they typically don't have as thick of a muscle layer wall, but they don't need to, do they? Do they? No. So right. And we said, so these large arteries to medium-sized arteries to smaller arteries, right? We said that kind of makes sense, that the pressure's going down and you're seeing these. But where is all of the nutrient exchange occurring? Capillary beds. And as this blood is potentially moving through, it doesn't get to stop. It's got to keep flowing. Got to keep flowing. It's going to be returned by way of small to medium to large venules, eventually to small to medium to large veins. Now, we said the pressure is going down. So how in the world, if you think about pressure needing to be low enough, as capillaries that are feeding like your little toe tissues, right? So they're feeding those tissues. How would blood be able to get all the way back up to here, to the right side? The pressure. Well, the veins do have muscles, don't they? And what can muscles do? That smooth muscle, and it can contract. I should have shown you the capillaries, but let's talk about this for a second. It can contract, so they do, and they're affected by contractions. But the pressure is pretty low. So guess what veins have that they need to ensure one-way flow that arteries don't have because they don't need it, the anatomy of it. What do veins have that arteries don't? Valves. Veins have valves and arteries don't have to have valves because between each heart rate, boom, 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 pushing. What would blood want to do in the vein? Between them, it would want to come back down, but it won't come back down because what will close? The valve. So between each heart, because we said in veins, the pressure has gotten pretty low, hasn't it? But valves will ensure that the blood is still going in one direction, even if it's against gravity, right? What do we call it in a wish I had a pen. What do we call it in a person? So this is a vein, okay? This is a vein. And we said that we have a valve here. So blood is having to go up. And between each, and this will open when blood is pushed up, but then it will close back down between the heartbeats. So blood won't come back down. And the next heartbeat, it'll open back up. You get what I'm saying? What do we call it when people in their veins, the valves are faulty? So the veins are not functioning the way they should. So between heartbeats, between heartbeats, these valves are kind of not doing what they are supposed to be doing. Blood will pull back down and the vein will stretch out. What do we call faulty valves and veins leading to potentially varicose veins? That's exactly right. Varicose veins. That's because of faulty what? Valves. So blood ends up pooling back and stretching the veins out. And once a vein gets stretched out, can the muscle, no matter how, whatever, can it really help with that blood flow? No. So this is usually an inherited kind of situation. You know, people either going to have varicose veins or not. What do we call varicose veins that are in the rectal region? Hemorrhoids. That's what we call varicose veins in the rectal region. Can they be large enough that they're even external? Yep. Yeah, you know, painful, you know, whatever. All right, so great. But we said before you get to the veins, what were the layer that is going to be all the nutrients exchanged? Now look at these capillaries. Do you see they're single layer thick? They're so small, the lumens are so small that red cells have to be wiggling in. It's almost single file. And of course, the extracellular plasma is called what? Plasma. Did I say extracellular? Yeah. Is it almost noon? Yeah. I have no excuses. But okay. The extracellular fluid is called plasma, and all the good stuff in blood that y'all saw in your blood films, platelets are having to go through, all the nutrients in plasma, the plasma protein, they go through. But if the lumens are tiny in these pathways, and they've got these little pores so that solids can move, they're called fenestrations, so you don't need to know that, but it can happen quickly, because blood doesn't get to stop for things to get off, do they? Or pick things up. It has to be moving. So as it's moving, all this transfer is actually happening at this capillary level. And this is an illustration, but this is an actual scanning electron micrograph of an actual capillary vessel. Is that so cool, isn't it? They truly are porous, aren't they? Do you see how porous looking that looks? So anyway, veins, and this is FYI, but if you ever wondered like where your blood is at rest, like what's happening, where's most of your blood, this is at rest for an adult where we kind of see most of our blood. Now let me talk to you a minute about blood pressure. What do we know about the top number on the blood pressure recorded? It's called what? Systolic. It's called a systolic pressure. That's exactly right. And systole meant what? Systole meant what? Contraction. And then the bottom number is what? The diastole or diastole. You'll hear it referred to as that. But anyways, it's where relaxation is occurring. So what does that mean? What are you measuring? When you have the top number and the bottom number of the blood pressure, what are you actually measuring? Because you would need to know this. What'd you say?
The contraction and the resting.
You're of what?
The ratio.
The valves.
Ask the question again, please.
I don't know what I asked. So, I said, what is it relating to? What is that the measurement of? What is that the measurement of? Force of what? Say that again.
The force of the blood going out of the left ventricle.
You all know that you can take blood pressure in different areas of the body, but we usually do the brachial. We use this brachial. What does brachial mean? So we usually do a brachial blood pressure here, and what we're measuring is the force when the left ventricle contracts, the force it's exerting on that arterial wall. The highest amount of force is the top number, meaning that the highest amount of pressure that arterial wall is having to withstand is when the left ventricle is at its highest. Right? Do y'all see that? So what you're measuring is the amount of pressure being exerted on that arterial wall, the inner arterial wall, when the left ventricle is at its highest force. That's what you're measuring in millimeters of mercury. You're measuring that pressure. the bottom number is the lowest amount of pressure that arterial wall is ever having to withstand, which correlates with the left ventricle at its most what? Relaxed. Which number is the most important number?
The pressure, the highest pressure.
This is not because that's how.
That's a some good questions. Let me just tell you something. They're both important, but many people would suggest to you that and many people would suggest you now. Obviously, if the systolic pressure is so high, you're about to have a stroke. That's taking over. That's the most important. But many would suggest to you that bottom number might be the most important over periods of time, because that's the least amount of pressure the poor artery's ever having on it. It never gets a break less than that. So if that's constantly chronically high, is that a problem? Yes. They're both important, and I do want you to know that they are both important. But anyway, so what's a normal blood pressure? And it says up here for a young adult. So the American Heart Association just changed these not long ago, didn't they? They just changed the recommendations for considering the blood pressures of adults to be. But I need you all to know that to be normal at rest, resting blood pressure should be, the systolic should be 120 or less, 120 or less, over less than 80. And this is in millimeters of mercury. You ever get a unit, make sure you know what the unit is. It's millimeters of mercury, right? So 120 millimeters of mercury, which is pressure, and or less than 80 millimeters of mercury for the diastolic. Now, what's considered low blood pressure? Less than 90 over 60, at 90 and over 60. If it's getting much less than that, then you're worried about hypotension, that like it's getting low. Some people have normal resting blood pressure of 90 over 60, and that's normal for them. That's normal for them. But there are other people, if they go to 90 over 60, you're worried about them because that's not their normal, right? Right? So people should know kind of what their normal is. They should know that, and they should routinely check blood pressure. Why?
I just have to ask a question. If somebody has the low blood pressure, just that's their average, and
No, 90 over 60.
but it
It
goes,
shouldn't be lower than that.
but it goes to a more average one. So let's say 20 over 80.
120 over 80.
Would that be considered for that high blood pressure?
No. Because what do we know about blood pressures anyway throughout a day? They can change. But what that person should do, if they have changed and they've changed in a short period of time, and there's no real reason that you're seeing that they've changed that much, it should definitely be watched. Do you know what I'm saying? Because you wouldn't want them to get much higher than that. Vessels can actually kind of withstand. That's actually an okay thing. Now let me tell you what is hypertensive. Hypertensive is anything over 140 or higher, or over 90 is the diastolic or higher. That's hypertensive. That's hypertensive every day. That's hypertensive. If you're falling somewhere between the 120 and 140 as a diastolic, and between the 80 and the 90 that's the diastolic. 120 and 140 is a systolic. You with me on this? That's considered pre-hypertensive, and it's considered a condition. So it's considered pre-hypertensive, and actually many people now, the American Heart Association is saying that that's hypertension. So people are really needing to watch their blood pressure, aren't they? And why? Because hypertension is a silent killer. What does that mean? It's called the silent killer. Why? Why is it called a silent killer? Who wants to? Some people are mumbling. I don't hear what you're saying. Which is
just get sick one day and go on and pass away and people be like, well, what happened?
Yeah,
You had
because-
high blood pressure a long time and you just passed.
Well, actually, it's silent killer because usually they know signs and symptoms. Nobody's coming in and saying, you know, now some people do have signs of hypertension. They'll have had it, but they'll all of a sudden start having headaches, or they'll have nosebleeds, right? Or they'll have something that makes them come in that's related to hypertension. But most don't. Most people have no signs, no symptoms of hypertension. The only way they would know is if they had routine what? Screenings. And what we know about hypertension is that chronic hypertension over time can cause sudden death. It can also cause like chronic loss of kidneys and of other organ damage. So people need to know if they're hypertensive and they need to address it, right, with treatments. They really do, because you can't live for extended periods of time with chronic hypertension. So for low blood pressure, if somebody, it's rare that I've ever seen anybody who gets told that because of their 90/60, is due to have a low. And I could almost tell she does, because she always is doing something, moving a foot or doing something. You can tell, and also smaller people can have, but I can almost tell she is because of how she moves. Because if you've got low blood pressure, you better be moving, because that's helping you to do what? Keep the blood moving. It's helping you to keep blood moving. And you'll notice people who are like 90/60, they do that. But no, there isn't anything that you really need to do for that. But if you ever were dehydrated, are you going to be in serious trouble in a quick hurry?
Yeah.
So you know, people who are normally low blood pressure, normal range, they are going to be even more susceptible to things, electrolyte imbalances, dehydration. You're going to watch them a little bit more carefully, because it's not going to take them as long to get into some trouble with that. But there's really nothing you can do. Stay hydrated, you know, stay hydrated, say whatever. That's just normal for you. The problem comes when people have sudden changes. So what you will see is with people who are who have traumatic accidents, and they will hemorrhage. That's taking their blood volume down. That's dropping their blood volume. Or they will even just not even be hemorrhaging, but you can have emotional, stressful situations that will change blood pressure enough that it drops it quickly enough that the nervous system can't compensate for it. So that person is typically going to be out, because usually if they're out, then their body systems can try to compensate, right? You get what I'm saying? So there's different types of shock that we'll talk about, but anyway, does that make sense? Mm-hmm. So when people are doing blood pressure, and I look like I had half the class that you guys are the pros here. One of the major things they do, for those of you who haven't taken them, is the cuffs are the wrong size. Yep. Cuffs have to be the right size, or your blood pressure results are worthless. Cuffs need to be the right size. Putting the cuff on correctly, using your stethoscope, knowing how to use your stethoscope, that you don't have your thumb on it. Why? Because your own thumb has what? A pulse in it. And what you're listening for is that person's blood flow. So you pumped up the cuff. Another thing that people do is they pump the cuff too friggin' high. You don't really have to do that. Unless you know somebody is always really extremely hypertensive, you're gonna have to catch it that way. But usually you don't have to do that if you're just checking. But they pump it up too high, leave it on too long. That's a tourniquet. That's actually that's an external risk to that patient. So you really shouldn't do that. And then they release the cuff pressure, listening to the boom, boom, boom. They're listening. The first sound they hear, where the gauge is on the sphygmomanometer thing, the first sound they hear is the systolic pressure. And then they're hearing boom, 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 and their gauge is going down. And they're having to really, really listen. And then it gets very, very faint, 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 faint. But the last sound you hear, wherever the gauge is your diastolic value. But what I see people do is they think the bounce has something to do with it. It has nothing to do with it. Nothing to do with blood pressure. And another thing that people do is they put the cuff over clothing. Wrong. Don't do that. Another thing that people do is they think, okay, I missed that first sound, let me pump it back up real quick. Wrong, your blood pressure is worthless after that. Don't repump that. Don't repump that arm for 5 minutes, because if they throw a clot, it's on you. It's on you if they do that clot. Take it to the other arm, try that one, and then 5 minutes between. Most of the time though, sometimes, especially my emergency people, they're having to do it in emergency situations. So, you know, it can be tricky. But still they should follow all those same rules, or the reading means nothing. By the way, a lot of the nurses now are getting used to the monitors that they're doing instead of the sphygmomanometer and the stethoscope. That's really wrong, because that's the gold standard. It's the gold standard for blood pressures. People should keep those skills up. I have those that we can use. Y'all ready to go over?
Sorry, you told us what the normal and the low and high are and stuff, but what are we, like, is that what we're gonna do over there? Just you're gonna tell us what we're pumping up to, and because I know nothing over anything like that.
So my experts, I just told you some things you don't want to. I just told you some things that I've seen so-called experts do that shouldn't be doing this, because it makes the reading erroneous. It's not even valid. And I can't tell you how many people I've had do those things on me, and I just think, okay, I teach at school, I'm not teaching you. So I don't even tell them. What'd you say?
Holding the arm up.
Holding the arm up above the heart, right? So you've had them doing that. You see them do a bunch of stuff, I know. So guys, experts will show you one. They'll show you maybe by doing yours, and then they'll help you do one. They'll let you do one. How many people haven't done one? You can't be expert at the beginning. Y'all, the nurses have those little blood pressure checkings all the time, because they're trying to get their skills up. And so it's really good to go down there and let them get their skills up. I went, one of the last times I went down there, they had the pump on off. So, but that's nothing bad about that, because we're learning, right? But people need to learn. Nobody's born knowing how to do these skills. You have to practice, ask a ton of questions, right? So, I've got different size cups. I've got stethoscopes. I would really love it if y'all would also, who am I? I know I've got a ton of experts in here. I would love it if y'all would also show this radial pulse, right? This radial pulse, and feeling it, and trying to do maybe a minute of that, and just feeling somebody's pulse. Especially if there's anybody who knows they have arrhythmias, you can really feel it. You can actually pick it up on somebody if you are feeling for a whole minute. And then we'll get some hearts out too. We're going over. Okay. Sure. Yes, Jada. So Tuesday, you are going to have a gimme lab that I am going to start you. Doesn't matter where I start you as a red blood cell, does it? Could I start you in the left ventricle, in which you would know what you passed? Because you're only going in one direction. No backflowing, right? So you don't know where I'm going to start you as a red blood cell, but I will start you somewhere, and you will list every structure you enter or pass by, like a valve, until you get back to that structure. Fair? That's what we counted as a lab.
We don't have to do all the way to the capillaries.
No, you just have to do what I told you. You don't have to, just what I told you. And then you'll also have a lecture quiz. You guys, y'all realize that, I kind of told you that the hardest part of all of A&P, 1 and 2, is what you all are in right now. The endocrine and cardiovascular. But we're about to finish the cardiovascular, and y'all are going to have a test on that soon. So please study the hematology, cardiovascular, and we're almost finished the vessels. That's what I want you to know about vessels. We're almost finished it. Please be studying it so you're ready for that next test, so you can bring up test grades if you can on this next test. Because that next test will probably be a week from today. A week from today on the cardiovascular system, hematology, heart, and vessels. So please be studying for a lecture quiz, but also be looking at the clinical insights and disorders in these chapters, because you probably have a test on this a week from today. Fair? Now, here's the good news. After that, students tell me, oh, this is getting better. My goodness. Because after that, it's lymphatic, which actually we people know very little about going in, but it just doesn't seem as hard as others. And then respiratory, urinary, digestive, and reproductive. One of your tests this semester will be a take-home test. One of them will. That gives you a little bit of a breather, doesn't it?
Sure.
It really, no, it really, I know that it really will feel that way. But let me warn you again about what your final exam is in this class, and it counts as a test. What's the final exam? Mostly hormones. So those of you who didn't do too great, that's okay on that first test, but it's going to kill you if you don't do well on that final exam, because that's 2 test scores and they're hard to overcome if you don't do well on it. If you did not do well on that endocrine test, you need to be continuing your study of that endocrine system, because that final exam is on all hormones and endocrine disorders. But I'll tell you right now, it's mostly hormones. Did you have a question, Alexis? No, okay. All right, let's go over that and start doing blood pressure cuffs. Y'all are kind of in this together, doing blood pressures and